Episode 18. Vic, I'm going to Vegas tomorrow.
I know, to defend your world championship.
I'm going to...
Everyone's out to get you this year.
I'm going to compete, not defend anything. I'm going to compete.
But you are the reigning world champion.
I'm the number one seed.
Yeah, and you won last year.
Yeah.
So I consider that reigning.
Yeah. I've trained as well as I can train, I think.
Yeah.
I've not skipped training. And I just got sick for 1 week. So I missed a couple of training sessions. But if I was able to train, I trained.
Yeah.
And I've been very dedicated and getting a lot of sleep. And so
and
I really should be more nervous. I feel confident, but you also never know who's going to show up. And so, I think just that unknown is the only variable.
That's the problem with being, returning as the champ from last year. Is everyone is studying film of you.
Yeah.
And you don't know who's going to show up.
Correct.
What was your seed last year?
14.
Yeah, right. There's some 14 seed that's like working on a new move.
Dude, listen. I absolutely expect him. You know what I mean?
Yeah.
I'm expecting him, and I'm.
That's the fun of it. That's the challenge.
Yeah,
that's why you'll be
challenge.
Celebrating. Is it Sunday night or Monday night when you're celebrating?
It'll be Saturday night. It'll be Saturday night. But yeah, it is interesting. It is a very, very different thing to quote unquote defend than it is to win your first. It's a very, very different thing.
Well, we were talking about this offline a couple weeks ago, but just that whole training process of you're fighting against another guy, even if it's here in Nashville, just sparring, and you can't be thinking about what you're going to do in a portfolio company board meeting in a week. Like, you have to be totally focused right then, and you get kind of immediate feedback on if you're doing well or not well.
Yeah. Yeah. Well, I feel like I've done a good job of putting issues to bed, letting everyone know I'll be out of office until September 11th, because we're going to we're just taking some downtime next week.
Yeah.
After all this good stuff.
Well, I have a lot of confidence in your ability to defend, and also I'll say on Saturday night I'll be hanging around. I don't know, eating pasta. And so it's really impressive that you'll be out there fighting other guys, trying to choke them out.
Well, thank you very much. It does add perspective. I will say, just before we sort of jump in, getting to this point, we're 48 hours out. I'd say the overwhelming feeling is a feeling of gratitude, like for my ability to even do this, and to me, it just, it really brings home the importance of the work we're trying to do here. Not just on this podcast, but, in our day-to-day lives at Jumpstart. There are so many people who, anytime I get worried or, scared or anything like that around the competition, I just remember I get to do this.
Right.
There are so many people right now who would trade anything with me for my anxiety about competing to be able to do it. You know what I mean?
Yeah. To compete at that caliber on that stage.
To have the physical wherewithal to compete at all. To, maybe even have the mental health, right?
Yeah.
To be able to train and to consistently, dedicate time and energy to something like this. So I'm largely going into the competition with a pretty deep sense of gratitude for my health.
Yeah.
Honestly.
Well, I'm super impressed with the work you've put in, and I think it's going to pay off.
Let's get to our favorite topic.
Yeah. So the economy, it seems like there's always news about the economy. And we talked about this in July. This is retail sales. So a group called Redbook, they track retail sales in the U.S. every week. And we brought up that in July it had gone negative, meaning it was lower. We were not having growth. We were going backwards.
Yep.
For the first time in several years.
Right.
And so I think it's worthwhile to now circle back and say it has recovered from there. And so if you're watching, you can see sort of it went negative for 3 weeks in July, and then it's recovered, at first pretty low.
Modest returns.
But last week was 4.2% growth, which is really impressive. Maybe that's back to school. There's lots of discussion on various places I'm trying to follow about how it may be higher than the steady state, but it's not negative. So it's real positive that it's come back.
Yeah. So the St. Louis Fed and their prediction around GDP.
Maybe they were right.
Maybe they know something we don't know. And then also job openings, which are, I think this is the lowest ratio they've been in what time period?
It's in like 2 or 3 years, I think. Okay. So they measure the ratio of open jobs compared to unemployed people.
Right.
And I think it came down to 1.5 jobs for every person that is looking for work. It peaked at 2 or 2 something. And so there are fewer jobs than there used to be,
right? Which
I guess is moderately negative. But there's still a lot of jobs out there, and unemployment is fairly low. So it's down. It seems like it's a pretty good set of reports this week.
Yeah, there was a story in the Business Insider. The headline was the Great Resignation is over, and it was just sort of saying, especially for white collar workers, we've had a sufficient number of layoffs, as well as companies tightening up as they feel uncertain about the economy, that now the combination of those two things have sort of flooded, open jobs with lots of laid off people applying, and that is making people who have jobs a lot less, open to quit. So there was this window, probably 2-year window, where if you were looking to hop from job to job to grow your salary, it was a great time.
Yeah, that was a good strategy.
It was a great time.
Right.
But at this point, the leverage has shifted back to the employers.
Yeah, but it's not
so much.
Not so much that we're looking at a huge recession right now, at least.
No.
So I mean, all in all, pretty good week for the economy.
Yeah, I don't think either of these trends, along with the current state of inflation, especially based on Powell's words last week, indicate that he's going to be stopping. So I'm predicting more hikes before the end of the year.
Yeah, and I mean the thing that he spoke Friday. We both listened to it. There wasn't anything really material to call out, I don't think. He just kind of was talking about they are almost like experimenting and trying to figure out what the right rate is to sort of guide the economy lower, but not too far. And I was struck with the U.S. Fed employs more PhD economists than anyone in the world. If they don't know what's going on, I don't know how you and I could know what's going on.
And they don't know.
So I mean, it seems like they're going to keep rates really high. They might even raise a little more until something breaks. I'm not sure that's the best strategy, but it seems to be what the Fed's doing.
All right, let's start a run of Wall Street Journal stories. The Wall Street Journal's been really active covering healthcare, which I appreciate, but also covering venture capital, which is nice. So they reported that Questa Capital closes a healthcare venture fund at $397 million. They had to point out that they didn't hit their $400 million target, but I think that's pretty irrelevant at $397. And this is a growth stage investor, and they are looking for companies that have between 5 million to 40 million in revenue. So 5 million, not an easy number to hit in the venture space. Just to be clear for anyone who's not familiar with the venture space, especially if you're talking about early stage venture, 5 million, that's real money. That's real money.
Yeah, it's a growth platform.
And that's the bottom edge of their capital stack, right?
Yeah, I mean, I think it was interesting that they got out. Yeah, maybe they didn't hit the 400, but 397 is pretty close to their goal.
That's right.
And they're focusing on healthcare, connected medical devices, and then also kind of value-based care. And that's an interesting space. I think the growth market is pretty crowded with other funds as well.
Agree.
But happy to have more money out there.
Yeah, no, look,
for our portfolio.
I think it's good. We definitely want more growth funding out there. I mean, it definitely feels like healthcare has found its way to be a little more resilient in the venture space in terms of funds being able to get raised. We talked about CD&R, which is not exclusively healthcare, nor is it even venture. They're PE, but they have a very, very strong healthcare portfolio. And it's just great to see this news. I mean, as often as we can, whenever we see new funds getting raised, especially if they're substantial in the amount of capital, we're going to shout it out because as early stage investors, this is the part of the capital continuum that we need to continue to be in place.
That's right. It's great to see. And a fresh fund means they won't have any of the old
Vintage.
kind of marked up things that they're trying to work through, which would be great.
That's right. And it also means that they are going to be, I think, bargain hunting. Wouldn't you say?
Yeah, sure.
And to that end, Wall Street Journal also put out an article about what you and I know because we live it every single day, which is startups hitting a funding wall after the seed stage.
Yeah, so there is a pretty big gap, I think, between where we live in that seed, just getting going, figuring out how do you get your product to fit with what the customers want and kind of get up and going to where you're at $5 million or $8 million in revenue, and Questa can fund you or someone similar to them.
Yeah, there's a gap.
That Series A, maybe Series B, there's a big gap there.
Yeah,
and that capital is not around right now.
No, it's really, really tough. So I was actually impressed. They interviewed Avlok from AngelList, the CEO. And his quotes are, the graduation rate to Series A is way below historical norms. There's just not that many people writing those bigger checks. We've been telling the broad Jumpstart Health Investors portfolio that for well over a year now, and we're living it for sure. Now, companies that are killing it have predictable revenue, have proof of, attractive growth, sort of 2x year over year growth. We're seeing those companies get to a Series A, especially, quite frankly, if they have very clean business models. If it's a SaaS business, that's very straightforward and easy to understand. But, I would say some of these more exotic business models, tech-enabled services, it's just harder.
Yeah, and I mean, Avlok, I think, had it the right way. Like the graduation rate declining, maybe it was 40% would go on from seed to A, and now it's half that. And so it's not that no companies will raise Series A, but it's a lot harder. You have to be everything buttoned up, really growing quickly, and it's still then a hard path to go. There are funds, but it's much tighter today.
Tell me how familiar this is. Ravi Sandapudi, who's the chief founder and chief executive officer at Effective, which is a fintech company, says he chose to raise a second seed round this year rather than proceed to a Series A to give his San Francisco fintech startup more time to build its business. His quote, given the VC market getting tougher and even broader volatility in financial markets, having an even longer runway was good for us. Yeah. Have you heard that before?
I have heard that. I've architected things like that before. I mean, what you call around is BS, right? Like, so, I mean, this summer I led another, maybe the 7th round in one of our portfolio companies, and we called it an A because it was more attractive to call it an A,
right?
Even though you would normally go through the letters, and you don't start at A. So you can call it anything you want. If you have already raised a seed round and it's not new investors, then that is pretty normal. Like they put in some more to get you going. But if you bring in all new investors and reprice it, whether you call it A or seed 2, it's still your second round.
So I have a question for you about this because we don't know when the Series A is going to come back, right? We're seeing PE funds getting raised. We're seeing growth funds getting raised. Yeah. But that's not Series A. We don't know when the Series A is going to come back. Let me just speak directly. I have been telling, various companies they need to have very minimal cash burn, or maybe even be cash flow positive, right? And I'm also preparing to do these sort of seed 2 checks, right? So we've
in your portfolio companies.
In our portfolio companies, yeah. We've gotten really, really stingy around reserves. And when I say stingy around reserves, I mean less focused on new companies and more focused on making sure we can support the companies we've already backed make it, up to the next level. We used to think about graduation as being a Series A, but in some of my companies, right, it's like if they can figure out how to do it. So I've got one company in the portfolio that it's feasible that by next summer they could be 5 million in revenue and cash flow positive, right? Without a Series A.
Yeah.
And so like I wonder for us,
they can go to growth.
They can go to growth. This is my question for you, right? Like as seed stage investors who have now had to go a full year, and we're heading into a year and a half of not having any Series A investors, do you feel like we may start just changing our entire model and thought process to be like, screw the A? I mean, we'll do several seeds, we'll get these companies oriented. And now not every company can do this, right? But
it depends on the business model.
Depends on the business model, right? But where possible, we'll do several rounds of seed. We'll get these companies to that really healthy place. We'll end up acquiring a pretty strong cash position because of that, right? And then ship them to growth, ship them directly to growth.
Yeah, I think that there are times in the marketplace where that is the strategy that is the best strategy for a VC. So my new fund, that's all I'm invested in. Seed companies that have a business model such that they can get to cash flow positive with this round of money.
Right.
And they have to execute, but that's a very different investment thesis than would have been really smart in 2016, 2017.
Right.
When it was much more about gathering revenue and market share, and then there were really welcoming exit markets.
Yeah.
I think about it as an exit market thing, and then it filters down. The A investors are really excited if they have a clear path to, okay, 3 years from now, we're going to be able to sell this based on a revenue multiple. I think that's gone now. Like there aren't revenue multiples. There aren't really a lot of exits going on at all, but when they are being traded, it's a strategic buy, and it's based on, cash flow.
Right.
Or it's a combination of EBITDA multiple, cash flow multiple, and revenue multiple in combination. And so I think for us, I think we should modulate back and forth, right? So right now, I don't see revenue multiples coming back. I don't think the A market is back for 2 years, 3 years, 4 years. And so
that's a pretty long time.
Yeah. So if I'm doing a seed,
that's a whole nother fund cycle.
Yeah. So this entire fund is, I've said to my LP, so I think it's okay to say it on here. I'm invested in 10 assets. They're all going to be seed companies, and they're all designed to get to cash flow positive, viability, and internal growth with their own cash flow with no more money coming in. And I think that could change if the Fed changes, and in 2 years, hopefully the Fed will shift, and that might change, but it's going to take a long time to filter through, right? The way the VC market is at the tail end of everything. So when the Fed changes, the public markets will react first, then private equity, then growth, then A. And then it goes the other way too. Like when it shifts negative, public markets correct first, and then we correct last. So we're at the tail end of this whip.
Mm-hmm.
And that, I think you have to plan for that.
Yeah. Well, I feel like I want to go back and kind of look at where VC was from 2000 to 2010. Because, seed wasn't around forever. Series A used to mean something very different, probably a lot more similar to seed. And it just seems to me like if it's not going to come back for the next 4 years, seed investors are going to have a completely different model to execute. And I think for a year we've been talking about, do entrepreneurs really understand sort of the difference in the market? Now I'm starting to shift to like, do seed stage VCs, like, do they really understand that graduation to Series A for some meaningful percentage of your portfolio should not even be the goal, right? You know what I mean? Like you really need to like build a business, functional business, and you should target trying to get to 5 million without a Series A.
No question.
You know what I mean? That's just a completely different mindset. I think most seed VCs are talking 1 to 2 million.
Yeah,
that's what they're.
There aren't many VCs as old as me and as poor as me. Right? So like, what I mean by that is the last time we saw this market was 2001, and I was doing deals then, and I saw my first pay to play, like really aggressive down round in 2002. And you learn, like, I took a lot of pain in those rounds because I wasn't reserved well. We didn't have the right business model. And most VCs haven't been investing since 01, 02.
Yeah, I haven't.
Or if they were, they have made so much money that they're on their private jet and they have other people doing things for them. You have to be, kind of a glutton for punishment, or really, I happen to really like working with the companies. And so I've in it for a long time, but there aren't that many VCs that have experienced this kind of market before. So I think you're right. They don't understand that the business models that can be financed are different today.
All right, let's shift to some healthcare stuff. Really, really big developing story. I think I mentioned this when I was doing my rundown on Aspen Health, and HHS Secretary Becerra was talking about. This was actually, I think, the one big win he positioned in that talk, which was that HHS was going to be able to negotiate drug prices. And he said, I have my top 10 list. He didn't divulge what those 10 drugs were going to be, but here we are. The list has now been published. Wall Street Journal's article headline is "Expensive Drugs Targeted for First U.S. Price Negotiations. The lower prices would take effect in 2026." And Vic, break this down. Let's first talk about what the categories of the drugs are. Let's talk about sort of what the spend associated with those categories is for CMS and ultimately for our country, and then the negotiating model.
Yeah, so they didn't announce how they chose these particular 10, but I think it's fair to assume that they chose drugs that have a very significant cost effect on Medicare or Medicare and Medicaid, and then they tried to go across different disease states. And I think you could maybe quibble over one or two, but they basically picked 10 expensive, widely used, and pretty effective drugs that are certainly expensive. We're talking about heart disease. I don't know. Go down a little bit more. Diabetes, cancer.
Yeah,
it's basically the really bad.
The top killers.
It's the top killers. It's the disease states that a lot of people in Medicare have. And so that's why they cost, that's why the total spend is a lot.
Right.
And then sure, each one is expensive. In total, last year on all these 10, the government spent a little over $50 billion. And so it's a ton of money.
Yeah. Big number.
And it also, I think we have to say that the government spent $4 trillion. Well, the government spent $2 trillion.
Right.
The whole market was $4 trillion. And so, well, it is a big amount of money. It's $50 billion. It is a small aspect of the $2 trillion that the government spent. So it's important work to do, but I would rather there be a more broad-based try to get drug pricing across all the drugs as opposed to pick 10 for kind of unintended consequences reasons. I think there's going to be games that the manufacturers can play.
Well, before you get there, let's talk about the actual negotiating model.
Yeah, the negotiating model is ludicrous. I mean, I don't understand why they set it up this way, but the model is CMS presents the drug manufacturer, so the top one is Bristol Myers Squibb, and Pfizer. They present them with a price that CMS is willing to pay. and the company can accept it or negotiate. And if they do not come to a negotiated price that both sides agree with, then all revenue for that drug in the United States is taxed at a 95% level. Not through CMS, but also through every other channel. And so I don't think that's a negotiation.
That's the stick.
They have this like big stick. We're going to put a 95% tax on the revenue of the drug.
Or you can...
Or accept this price.
Or you can remove the drug from Medicare and Medicaid.
Yes, you cannot sell to the federal government.
Which, I mean, can you imagine the PR fallout from that?
Well, I mean...
I mean, like, dude.
So I'm a free market guy, but the negotiation is not a real negotiation. Like, the government is not incented to put a fair price on the table.
Well, when you say it's not a real negotiation, I think what you mean is it's not a negotiation purely on the basis of the buyer, because the government has more weapons than just their spend.
That's
right?
like the Godfather.
They have the IRS. They have the ability to tax the company as well.
That's right.
So
they're utilizing
their taxing authority in addition to their wallet.
Yes, which I think will tarnish the negotiation, and it won't be a fair negotiation.
Okay, so the Wall Street Journal also published an opinion piece from the CEO of Bristol Myers Squibb, who is
same day.
Outgoing. Of course,
he was the only one that would do it.
Yeah, right. Of course they did. He's outgoing. So, and it should be said, there's lots of lobbying organizations. There's a ton of suits going on. So this, it's still unclear how this is all going to play out, but it was passed in the Inflation Reduction Act. And so, HHS at the moment has the authority to do what it's doing.
And they're going to move forward with these 10.
Yeah, they're moving forward. Yeah, they're moving forward with this negotiation. So, the article, the opinion piece by Giovanni Caforio, pretty sure I pronounced that correctly, basically says that this approach is going to stifle innovation. And TLDR, if you've ever looked at the way that the pharma industry works, especially the sort of US-based pharma industry, effectively, you can make an argument that the margin that is made on selling medicines to the United States makes up for a lot of the R&D cost that gets proliferated around the world, right? Because we are really the engine for innovation for biopharma and small molecule development. That's what we do here.
Yeah.
And so if you take out that margin, that's what's subsidizing the development and the distribution of these drugs around the world. And so it's going to drive, it's an economic move. It's going to drive economic actors to respond with some form of behavior, right?
Yes.
There will be consequences to this. We need to all sort of understand. I think before the show even started, Vic, you and I said, we don't know how to think about this.
I don't know what the answer is.
We're not going to take a position on this, okay? But I think laying out the situation is important because we are at a crossroads here. That either this negotiation fails to go through, and we're going to have pretty much I would imagine a status quo. If this fails, we'll end up having a pretty status quo situation with regard to pharma and the cost of pharma. We'll just have to sort of accept that. Or we will start this process where the way that pharma operates is going to really significantly change. So on one hand, you've got the government saying, we are your biggest customer. We spent $50 billion on drugs. Here is a list of the top 10 drugs that are, dealing with the top 3 killers of Americans. And, we have never been in a position, we've been price takers up until this point. We've had to take whatever price that you said. We've never had the authority to negotiate with you. We now have the authority to negotiate with you. It's our fiduciary duty to the American people to do so.
So far, I agree with that.
Let me keep going. Yeah, we have a fiduciary duty to negotiate with you and to lower the cost of these medicines, which we believe will cause less burden to families all across America, and also will hopefully increase access to these things as the cost has, dropped. So on its face, not as a domino that knocks 10 other dominoes down that we haven't even begun to think about yet. On its face, that seems noble and appropriate.
That's right, but that's not what they're doing.
Well, no. It is what they're doing. It's not how. There's a what and there's a how. There's a why, what, and a how here.
Every year, large employers, either directly or through PBMs or through payers, depending on how big they are, negotiate drug pricing. And they decide if they want to offer pharmaceuticals given the price they can negotiate, or they don't want to offer that in their formulary. And they literally have, like, our employees can access drugs through this means, and not everything is offered. That I'm fine with that. That is what the government should be doing. Well, but then going
the government
a step
and employers,
further,
the government and employers are two entirely different things.
Why? That's my question. Why?
Okay, so employers are economic actors only. That's all they are. And in the case of, as you and I both know, because we are employers, your benefits are part of your competitive advantage to attract and retain talent. And so therefore, like, if you have more cash available, you are fine paying for more things to have a stronger benefits package to defeat your competitors by attracting and retaining better talent.
Right.
The government does not have that same incentive. So that I don't want to say whatever employers are doing is exactly what the government should do, because they're just fundamentally not the same thing. The government is not here to compete with another government. I mean, maybe in some context, but not in this context.
I guess if they were negotiating around, we will not purchase your drug through CMS unless we achieve a price point that we both are good with.
Right.
That is a normal negotiation. And CMS has a duty to bring the best treatments it can find. But we've talked about this on podcasts, that it can afford. And the FDA has a different mandate.
Yep.
So CMS has taken this mantle of trying to balance cost and benefit at some level. And whether they do it great or not so great, they're working on that. They're trying their best to negotiate that for themselves. That they should be negotiating prices. They should not just take whatever price anyone gives. Where I think it falls down is when they turn to the Internal Revenue Service and have this extra thing.
Yeah, well, we're talking about the how.
The how. But the how is important.
The how is important. So let me ask you a question. Do you think that their first thought on how they were going to negotiate this included that? I just think it's an interesting stipulation to put in there, because it makes me wonder whether or not they felt that they had adequate leverage on spend alone to be able to move the needle in a way that was meaningful to them. You know, they put this really heavy stick out there, and again, I'm not taking a strong position. I'm more trying to unpack what happened here. Like, how did we get to where this is the model that we're doing this negotiation?
Yeah. So I have opinions, but I don't know how accurate they are. So
neither of us know.
So
neither of us know.
I will tell you my opinion, but it may not be correct.
Yeah.
And so my opinion is that I think it's fairly understood that if you are working for the federal government, you're doing good work for the American people, and you also have an opportunity to go to industry after that time in government, and you can make a lot more money after that. So there's like this revolving door of people who are in government for 10 years, and they do their work for the people, and then they go to a drug company, or they become a lobbyist, or they go and they make money. And those things are pretty well understood, that the hiring out of government administrations is pretty common, because obviously those people know all the ways that everything happens in government. So it's very valuable to the drug companies. And instead of trying to fix that, I believe that they felt like, well, given that dynamic, we're not going to really be able to negotiate effectively or aggressively, because people on the CMS side, they don't really have the right incentives. They're not working for a private company where they get a bonus based on what this drug spend is.
No, they get their kudos based on what kind of impact they're able to make.
And there's a lot of pressure to offer every drug.
Yeah.
And so I think they set it up this way because they didn't think they could actually negotiate.
That's what I think.
And that's
what I think.
That's what happened.
That's what I think.
But the way to sort of fix the problem of the revolving door is not just to say, well, forget it, we're not going to do that, we're just going to. So how are they going to pick the price? Just randomly?
Look, you can hire a lot of economists. You can figure out, all sorts of health economy ways to determine a price, right? I mean, there's a lot of ways you can go about this. I think that it is a very, very hard problem. This is a super, super, super tough problem, and to me, it's a great symbol of just how challenging this industry is. I mean,
maybe I think I believe that CMS is the number one top revenue provider to pharma. Okay. There are 9 more in the top 10, just by the fact that there's a list of the top 10 buyers of these drugs.
Of course.
Couldn't you just take the average price the other 9 pay? I mean, there are other ways to approach this that would be market-based and not dysfunctional.
But that doesn't necessarily, if the result of that is not politically satisfying.
I mean, it is what it is. Like,
well, no,
Walmart, GM,
that's not a political reality. What you just said, it is what it is. I mean, that's just a pure free market perspective on an agency that's like, agency is not political, but it's a political weapon.
I agree. We spend too much money, and I think if you look at the next 9 biggest buyers, their price is, all 9 of them pay a lower price. And so it is ridiculous that the biggest buyer in the market pays such a high price. But there are ways to do that in a process that would be fair.
You're talking about what the price is. You're not talking. I don't think they said how they're going to set the price. You're just saying if they don't accept the price,
I'm saying it's not a negotiation. It's a mandate.
Well, I've been in negotiations that had this kind of mandate before. I didn't like it, but the other side thought it was a negotiation.
I mean, it's the movie. It's The Godfather.
Yeah, sure.
Either your name or your brains are going to be on this contract.
Yeah,
today.
right.
And
right.
I guess it's a negotiation, but it's not a functional one. So
perhaps, I mean, what I'm more concerned about are the unintended consequences of it.
Yeah. So
if it does go through,
they didn't ask either you or me how to design this.
How dare they?
They would be much better off if we helped them with all these policies. So it's going to happen. And so let's talk for a minute about what the repercussions are, what the dominoes are that fall. This opinion piece, of course, has no biases.
Well, he's also on his way out, so he gets to.
But there's a lot of truth to it. And I think part of what I like about this podcast is talking through these issues in a way that you can then interpret news later, given all the different competing sides. There's no question that there are a lot of research projects that end in nothing. And you spend money because it's an R&D project that looks promising, but it doesn't pan out because biochemistry is hard. And when something does get through the process, the companies need to make an appropriate return to offset all of those R&D projects that didn't work. Mm-hmm. And we want to incentivize them to do lots of R&D because we want better drugs. Mm-hmm. And so if you take away the highest paying customer, almost certainly there's going to be less money for R&D. I mean, that's just a fact.
Yeah.
It's going to hurt the medications available to the globe, because you're right. We sort of provide a lot of the margin, and whether Americans think they shouldn't or not is a question we should talk about, but it's going to be less.
Critics will say they make plenty of margin. They don't need as much margin as they have. And that may be true, but they are independent companies, many of them publicly traded, who are beholden to shareholders, who will behave in the best interest of not just the shareholders, but the stock price. And so they will make they will respond to this in some way, shape, or form that protects their position.
Yes.
That's the part for me that I'm like, the repercussions of this have not been fully thought through.
They must protect the shareholders. That's their job.
Right.
And every American, starting with me, if I have something go wrong, I want the best drug I can find. And if I'm old enough, I want CMS to pay for it. And so we're setting up this system that's going to make fewer R&D projects. I don't know if it's a whole bunch fewer or just moderately fewer, but there'll be fewer R&D projects that can get done. And then there'll be fewer things that come out the other side that actually are working.
This rhymes very nicely with the Fed's impact on the venture capital world.
Yes. But before we go on, so the other thing that I think is just idiotic is to pick 10. I mean, I don't know how many drugs there are, but more than 10.
Yeah.
And Bristol Myers Squibb sells a whole bunch. Pfizer sells a whole bunch. J&J sells a whole bunch. They're just going to transfer price and move around and make everything else slightly more profitable.
Well, that's an unintended consequence.
Yes.
And a rational response.
And it would be solved with some market-based thing. And like maybe the other actors aren't as good at negotiating as the federal government would be, but it would be like repeatable. They do it every year.
Yeah.
So just picking 10 is crazy, but that's what they're doing.
Okay. That was a conversation that I feel like I'm no closer to understanding what the right thing to do is. But hard problem. I think as an American citizen, I think it's noble for our government to try to be proactive to control the cost of drugs, especially for the most vulnerable members of our population, and for us as taxpayers who all pay into that system. So that, as an American citizen, I think that is good. But I think, similar to the Fed, who wants to, lower inflation, that's also noble. The selection of tools with which they can do that seem really crude and seem to have a lot of unintended consequences. And I think just illustrate what a difficult problem we have on our hands.
Yeah. I mean, it makes voters happy.
Sure.
Right?
It definitely makes voters happy.
That's why it's happening in my mind. Like on both sides.
No matter
where you are, no matter where you're sitting, what primary you're voting in, you want the government to pay less for drugs.
I think that's right.
And so that's why it's going to happen.
I think that's right. All right, let's take a break. Let Doug share a little bit about Jumpstart Foundry, and we will be back.
Thanks, guys, for the opportunity to talk about our pre-seed fund, Jumpstart Foundry. My name is Doug Edwards, CEO of Jumpstart Health Investors, the parent company of Jumpstart Foundry. We're so excited to be able to talk about early stage venture investing, certainly the need for us to change the crazy world of healthcare in the United States. We are spending 20% of our GDP, north of $4 trillion a year on healthcare with suboptimal outcomes. Jumpstart Foundry exists to help us find and identify and invest in innovative companies that are going to make a difference in healthcare in our country. Every year, Jumpstart Foundry invests a fund, raises a fund, and deploys that across 30, 40, 50 assets every year, allowing ease of access for our limited partners to invest to help us make something better in healthcare. Some of the benefits of Jumpstart Foundry is there's no management fees. We deploy all the capital that's raised every year in the fund. We find the best and brightest, typically around single-digit percentage of companies that apply for funding from Jumpstart, and we invest in the most incredible, robust, innovative solutions and founders in the United States. Over the last 9 years, Jumpstart Foundry has invested in nearly 200 early-stage, pre-seed stage companies in the country. Through those most innovative solutions that Jumpstart Foundry invests in, we also provide great returns and a great experience for our limited partners. We partner with AngelList to administer the fund, making that ease of access not only with low minimums, but the ease of investing in venture much better. We all know that healthcare is broken. Everyone deserves better. Come alongside us with Jumpstart Foundry, invest in making the future of healthcare better, and make something better in healthcare. Thank you, guys. Now back to the show.
Going into another conversation of which I don't think we have an exact answer, but I personally have lived experience that makes me want to talk about it. So these were two great finds. Finally, we're done with the Wall Street Journal for a second. We have a New York Times article, an opinion guest essay. The headline, "Not everything we call cancer should be called cancer," and actually written by two oncologists, Laura Esserman and Scott Egner. Esserman is from the University of California. She's a breast cancer oncologist, and Egner is a urologic oncologist from the University of Chicago. So, I mean, I think it's a pretty straightforward. You can kind of intuit what it's about just from what the title of the essay is, which is that today we have this spectrum of experiences that are all under this bucket of cancer, meaning some cancers, you can live for a very, very long time with sort of some treatment that's very, very manageable. Some are a very short death sentence. But the word cancer still principally has the terrifying death sentence association with it.
Right.
And as a population, especially as we are sort of in the 1 out of every 2 people are going to get this thing, perhaps it is time to start thinking more thoughtfully and maybe consider renaming some of these disease states such that we don't associate ones that are very, very manageable with today's, medicines, with those that truly mean a death sentence.
Yeah, there are cancers that we have a really good understanding of the pathway that's causing the cancer, and we know how to interrupt it and treat it. And it needs to be treated, but it is similar to many other diseases that don't bring that terrifying fear-based moniker. Then there are some cancers that we wouldn't want to treat at all, that really the best course is to monitor them for sometimes a long period of time.
Right.
And then there are some that are really deadly. And calling it all the same thing is not helpful to any of those patients.
Yeah. And I love how they lay out their case. They basically say, look, we have advanced our understanding of cancer significantly with amazing innovations and research work that has been done. I mean, we've poured countless dollars into trying to defeat this disease, and we've learned a lot. We've made a lot of progress. And with all of that learning and all that progress and all these dollars and all this research and all these advancements and all these saved lives and all the cancer that's been put into remission, or people who've been able to live for decades with, almost no altered quality of life, we have not in any way updated how we talk about it.
Yes.
And that just seems crazy. That seems crazy. And then to even give us a little bit of a history lesson and say the word cancer is attributed to Hippocrates 2,500 years ago.
Right.
I mean.
Yeah. And the, the cynical side of me thinks cancer raises a lot of money for nonprofit health systems. And the fact that it is really scary is what causes donors to want to give a lot. And if you take away all the cancers that are very treatable and call them something else, it might become much harder to sort of get that point across. And so I don't know, there's all these embedded things that just are in part and parcel with how the system works that need to be updated.
Yeah, I mean, that's certainly one way to view it, and I could see that thought. I mean, my view would be, I think it would be really helpful if we delisted things that we've beaten, because it would show progress. Because cancer is one of those things that feels to me like we haven't made much progress, even though we have made a lot of progress, right? Because there are still those cancers that are incredibly dangerous. I mean, I think I was talking to somebody about HIV, last week, and how ridiculously crazy it is that you can live.
Yeah, it's
life.
It's fully treatable.
Yeah, you can live a life and not be,
there's
super dangerous
ads on TV,
dude. It's
go have sex. We got a drug for you.
Yeah. I mean, but that's a miracle of medicine.
Yes.
That is a miracle of medicine, right? And so I feel like the miracles of medicine in the cancer space,
and we don't celebrate.
We don't see enough of those, right? We don't see enough of those. It just feels like we continue to have this big, scary, looming thing, and maybe changing the names could be a path to that, right? A psychological path.
Yeah.
Demonstrating the progress we've made.
I don't see a downside to it. I mean, you could change it to the type of cancer, and they give a couple examples in the article, but it just gets, I don't know what half the things are my doctor talks about. And so getting the technically correct name and just removing the cancer moniker, I think I don't see a downside to it, other than it would be challenging for fundraising.
Well, I said that, personally having experiences, around this, I've got several family members, and nothing is unique about what I'm about to say.
Yeah.
But I've got several family members very close to me who are currently in a journey with this broad word called cancer, right? And they have different kinds of cancers in different stages. And I have to say, as someone who's very close to these people, it's hard for me to sort of parse out how I should feel differently maybe about each one of them based on what their diagnosis is.
Well, that's the problem, is that the patient is scared.
Yeah.
But it doesn't matter if it's a good cancer or terrible cancer.
That's right.
As soon as you hear the word cancer, it's over. You're in full.
You go right to the. Yeah,
you're in full
that's right.
crisis.
That's right.
And so you, as a family member, you have to be kind to them and sympathetic and empathize with what the fear they're feeling. I think this article is suggesting that maybe half of them or a third of them didn't need all that stress, fear, anxiety, and that actually may be worse than the sort of the treatment.
Well, I appreciate the article, and I love that it came from two oncologists.
Yeah.
We love to see oncologists and just clinicians, period.
Just contributing to help us
the
understand.
Discourse, yes, to the discourse, and helping us think about things that we're not thinking about, but they experience every single day, right? it's super helpful. Okay, switching to another topic around patients and
a lot of cancer diagnosis.
Yeah, right. So this has been a big story. You credited Kim Kardashian with her post on Instagram.
Well, she just blew it up.
Yeah,
I mean,
yeah, that's right.
She can blow anything up. Probably.
That's right.
Yeah.
That's right.
Yeah.
She's got hundreds of millions of followers on social. But this is the story about people getting full body scans, right? And these things are popping up everywhere. There's several new ones here in Nashville.
Yeah.
I saw friends of mine posting on Instagram that they went and they got them. But you and I, we've been hearing about this, both from the Peter Attias of the world, but also
in the longevity space and in the wealthy person space.
It's talked about.
The venture capital space is sort of a cross section of both those people.
Yeah.
It's been talked about for a long time.
Yeah.
And I sort of have two minds about this. Like I think individuals should be able to do whatever they want to do. And at the same time, if you get a full body scan, you will find a lot of stuff. And you have to have an ability to like take that information in and be able to navigate the next step in a way that is different than if you have like a symptom that's causing you pain, or you can see there's a real problem, and it can be wonderful, but I think it also can sort of put you down a road of you find something that, you might have died of this cancer when you're 190 years old, and you probably die of many things before that.
Right.
But you're now all worried about this very tiny cancer body of cells that, may have just have gone away or might never have followed up. So I feel like we should be able to do it, but it's causing a lot of people to sort of get spun up around things.
Well, the cancer diagnostic space is sort of one thing because, in that space, and too many people have stories about this to try to put this back in the bottle. Late diagnosis is a big deal.
Yeah.
And unfortunately,
cancer is asymptomatic largely.
Yes, exactly. And so unfortunately, we have not nailed the diagnostic model in our healthcare system today. We have not. Far too many people have died because of a late diagnosis. That's just the reality.
Yeah.
And some of that is physician judgment. Some of it is diagnostic availability. There's all sorts of issues there, right? And so for people who have a lived experience with the healthcare system that has gone negative on this side of things, or just believe that they should be sovereign over their body and have a right to have diagnostics over their own body, which they should. These scans are going to increase. We're going to have more and more people with these scans. And we even talked about how there's a generational aspect to this, where the boomers, I think were much more bought into physician sovereignty. And I think millennials are much more bought into personal sovereignty, and they have much stronger sort of trust and familiarity with technology. So they've been dealing with wearables and all this other kind of stuff. And so their belief is they should be able to have these body scans. One other thing I want to just bring up is I have to talk about Peter Attia, because I think when you're talking about these scans, he's kind of the physician leading the charge in pop culture, I would say. Yeah. Around getting more diagnostics. When he talks about medicine 3.0 in his new book Outlive, one of the fundamental principles there is sovereignty equals responsibility, right? So it means you as a patient, you have to become far more educated and aware, and you have to sort of have your own built-in protocol for what to do when you get these diagnostics, right? Which I think includes not freaking out, right? Like, you have to be able to get these things, look at them, and have a way that you engage with the healthcare system, the way that you engage with your primary care physician. We have so many people who don't have primary care physicians, partially because urgent care sort of replaced them, partially because we're running out of primary care physicians because too many people are going to get specialties, and we had 5, folks that want to do knee work and nobody who wants to do family medicine, right? So I just see this, and I'll just go ahead and say I haven't done the full body scan, but I'm going to. I mean, that's in my future. And a lot of it just has to do with watching members of my family just doing exactly what the healthcare system told them to do in terms of the number of checkups that they went to and the medicines that they had, and, being left towards the end of their life with just, a low quality of life. Things, especially, around heart disease or high blood pressure or any of those types of things that really could have been managed. You hear about the number of people who feel like they're fine and then all of a sudden they need to have, massive heart surgery. It just seems like there is a place for more diagnostics.
Yeah. So I read Peter's book. It's a great book. And I really got focused on the cardiac disease section.
That's the section.
Because both of my grandfathers died of heart disease. And it just made me worried that and so I didn't get a full body scan checking for cancer, but I did dive into cardiac disease and what's my calcium score. And then I got the full, whatever it's called, like a calcium scan of my heart.
Yeah.
And I have heart disease and have a blockage in the widowmaker. And it's called the damn widowmaker. And so it is not
breaking news. My partner just told me he's got a.
Well, my wife is on it. I'm on it. I mean, so it was good to read the book and dig into it.
Yeah.
And there are treatments for it.
Absolutely. Yeah.
But it's not symptomatic. So you can just be on a run and fall over with a heart attack.
Yeah. And for people who don't know, Vic, all he does is work out and go to sleep and he eats healthy and he doesn't drink. And you are a healthy guy.
I think, well, that's true. I think there's a lot of genetic aspects.
Yeah, of course.
And there's also just the U.S. American diet. I mean, I've been eating healthy for maybe 5 years, 6 years.
Yeah, yeah.
But I'm 52. So there were 45 years of not so healthy. And so I think I've caught it in time, but I've told my sons, they're in their teens now, but before you're 30, you need to start monitoring this stuff because so I think there is something about individuals taking control of their own health.
I mean, but here's what's so crazy. No doctor recommended you do this.
No.
You went and got the diagnostic and then you found this.
And I had to pay for it.
Yeah, of course.
It's not reimbursed.
No.
And then once you get the results, then they'll reimburse the medication and other once you see what you have a problem with. But yes, I think it's just, if you have the money and you're in the right generation and you want to take sovereignty over yourself, you should, but that brings a responsibility.
Of course.
You can't just sort of then give it up and be freaked out about all the things.
Right. So yeah. So I mean, look, I think the physicians
we're not going to put it back in the bottle.
No, it's not going back in the bottle. Right. I definitely think there's a generational aspect to this that's kind of like a boomers versus millennials thing.
Yeah. And just for the audience, we're both Xers, so I think you're an Xer. So we're in the middle. So we're not in either of the camps.
That's right. Although we're not in either of the camps, but
I side with the millennials. I side with the millennials.
Right, I side with the millennials.
They're just right more.
Yeah. But look, I think that between the hey, maybe we should think about what we name cancer and these full body scans, there's this growing narrative and conversation around the relationship between patients and the healthcare system, right?
Yes.
And it's not just about life expectancy, and it's certainly not just about bedside manner. It's about these more fundamental things. And to me, it's ultimately this physician sovereignty, patient sovereignty paradigm shift that it feels like we're in, which feels like a generational shift, feels like a technological shift. And
there's just outdated policies, right? So Pia thing around cancer, not cardiac disease, the risk profile is, are you likely to die of a heart attack in 10 years? And if yes, then we need to take that seriously and start treating it. And so I'm 52. So no, probably not.
Right.
But I want to live past 62.
That's ridiculous.
So 10 years is not my window. And so that's what really got my attention. And, I don't need to wait until I'm 62 and have a lot more risk factors because I want to live 40 more years or whatever, 30 more years. And so the policy of here's how we're going to risk profile people, depending on your age, that might be fine if you're 65.
That's right.
But it's not great if you're 30. And we have enough technology and enough education to be able to sort of understand that, okay, I got a bad score. I need to take a statin. I need to eat more. I need to do zone 2 training.
Mhm.
There's a bunch of stuff you need to do.
That's right.
And it will be fine. It's not a crisis, but
you have to make some changes.
Yes, that's right. Yeah.
All right. Shifting into some stories about EHRs. 3 different stories about EHRs, but sort of with a little bit of a segue. So Modern Healthcare put out a story talking about Common Spirit and Penn Medicine leading the way on confronting racial bias ingrained in EHRs. And Vic, we did a little prep on this because, you know,
I was completely ignorant about this.
Yeah, it's something I have lived experience with that you don't.
I'm embarrassed. I didn't know anything about this before like yesterday.
Yeah. So like the easy place to sort of start is EGFR, which is a kidney, rating.
Yeah. How functioning your kidneys are.
Yeah, exactly. And I've known for a very, very long time, if you get blood work, you have like, if you're Black, you have like a, EGFR, and then you have like an African-American EGFR, which is adjusted.
It's adjusted down.
It's adjusted down.
Risky. For the same score, it's less risky if you're African-American.
Yes, because in some clinical trials like forever ago, it looked like we have different readings. But of course, race is not, and certainly African-American is not even a race. It's a sort of ethnic
and
category.
The kidney functions the same.
Yeah. Here's the big deal. The kidney doesn't function the same in any 2 individuals, right? So the biological categorization of African American, that's a fundamentally flawed one because race is a social construct, not a biological construct. And if you based it on clinical trials, we're just now trying to remedy how poor clinical trials have been from a diversity perspective, like in 2023. So you have bad sort of clinical policy based on bad clinical trials, and then what's happened is that's all been baked into the EHRs, right, which drive clinical behavior. And so what's happening effectively, Common Spirit has said, we have these different readings that are popping up in our EHR systems, and clinicians are making decisions to delay care for Black people.
Let me just say this again to emphasize it because it was shocking. So this reading, EGFR, is a kidney function reading, and systematically across the country for decades, if you're Black and have a reading that is maybe showing kidney is not doing that well, they do not treat you for a longer period of time than if you're white, because there was some thesis that is not true, that Black people always have a high reading. And so I think that means they've gotten worse care for decades.
Correct.
And it's
and systematically so.
Yeah.
And even more systematically so since the advent of EHRs.
It's been then the EHR comes up and they put it in the system so that if the race is African American, it adjusts it and there's not a warning. Even though if I as a white person had the same reading, there'd be a warning that happens.
Yeah. And so that then drives clinical decision making and workflow, which results in
surprise, there's a lot of kidney disease in Black people.
Yes. So
Common Spirit and Penn Med are changing that.
Well, they're I would say they're
it.
leading the way in changing it. They're pushing to have it sort of changed in their own EHRs, but now they're sort of raising the awareness about this. And I think obviously it's great. Look, Common Spirit, we've covered them for a while. A large percentage of their payer mix, almost 70% is Medicare and Medicaid. They look, quite frankly, they have black leadership. So, and I've said many times, when you have diverse leadership, these issues are going to get dealt with, right? Because people are going to bring these topics, and look, it's just the reality of you didn't know.
I didn't know.
I've been in healthcare. You don't have the lived experience,
right?
And I've known, because I had the lived experience. I can show you my labs right now, and I've been looking at this, adjusted EGFR my entire life, man. You know what I mean? So
I mean, it just all three of these stories make me think that there's a reason people don't trust the medical system. We need to do a better job. We have to do
well. It's not perfect. I think that's the main.
It doesn't
thing.
have to be perfect, but it has to be with good intentions.
Yes.
I mean, nothing in healthcare is perfect, but it needs to be, first, don't do any fucking harm. And we're systematically doing harm by not screening people correctly. And then secondly, do the best we can to treat the patients. That doesn't mean everyone gets saved. I mean, you can't promise that. But this doesn't seem like it's the best we can do.
Again, I think that the veneer of, do as we say and physician sovereignty it's buckling under the rapid development of technology. Quite frankly, which is both more diagnostics in our hands, but also just more media covering this stuff, right? I mean, more people being able to tell their stories about what's going on. More physicians being able to have debates out in public. The fact that a Peter Attia can build his own media company that's that's effectively massive and hugely influential. Him and Andrew Huberman probably have the top 2 health podcast, not healthcare, health podcasts in America right now. And everything they're saying is empowering the patient, right? And so I just feel like the system is not designed to address this kind of onslaught, right? At its authority, at its fundamental authority to tell people, we know what we're doing, just trust what we say.
It's inherently designed for a patient having pain or some symptom. They break their ankle in the fields in the 50s, and they come in with a problem. They present, with symptoms, and we treat them and send them home. And that is important, but that we have chronic disease now, and we have all things that are asymptomatic. And so it's no longer sufficient. We need to do better.
All right, final 2 stories, shifting away from sort of the patient focus and just focusing on EHRs and technologies. We can drop this one really quickly. Another cybersecurity issue, the MoveIt breach hits Johns Hopkins and other health systems. Not much more to say. It's a file transfer software product, and it has impacted health systems. Again, we've had a breach of records yet again.
And this is a constant thing. Every few months, I feel like there's another breach. The healthcare systems in the United States are sitting ducks. They're good targets
honeypots.
With lots. It's honeypot with lots of data. It's very valuable data, and they're not designed to protect, to keep people out. So they're not going to.
Yeah, and they can't afford to bone up their IT capabilities to meet this onslaught. There was a line in this article here from Modern Healthcare that said nearly 25% of cyber attacks in 2022 targeted the healthcare industry.
Yeah.
I mean, that's insane.
It's a huge honeypot with a lot of honey in there, and no one really guarding it.
And like, it's not like if you think about the way that banks are oriented, banks can really control the vectors of access in a much more contained way. Healthcare systems, in order to deliver care, you got people everywhere that have to touch stuff. In banks, you can say, no, slow everything down by 3x,
right?
Because like security is paramount, and that's that works. And I think that's why you don't hear about banks constantly getting knocked over by cybersecurity attacks. Whereas in health systems, it's just, they're porous. There's people everywhere touching technology, moving in and out of rooms. It's just,
well, we've been talking about
everywhere.
Diagnostics and labs and things already, and the proliferation of those. I want my doctor at 10 at night from his or her home to be able to read what's going on with my labs.
Yes.
And yet, in order to deliver that, we have to have really secure and decentralized systems. And there's no money. So you and I could envision that being created, but it would be expensive. And so it's just not going to change.
It would cost a lot of money to adequately prepare the health systems of America,
which they
to
don't
protect themselves. And
they can't pay their people. Never mind.
That's right.
So it's just going to keep happening. And
oh, by the way, I'm not saying that this is their fault, but it certainly is going to impact trust.
Yes.
I mean,
yeah, it's another thing that makes you lose trust in the system.
Yeah. All right. Final note, which is actually, I would say, a bright spot.
If you survive through all of this down news, we have a great story. And
so our friend Mike Schlosser at HCA, who is an SVP there and is really sort of leading a lot of the innovation from the physician side of things. Yeah. He's heading up an entire initiative that's in their Lake Nona hospital, which is basically like this just innovation platform that they've built out, which is super cool. They are advancing generative AI at HCA in partnership with Google.
Yeah, which is great. And they are, we've talked about the listening and kind of doing the doc notes just by sort of listening around the sides. They're doing that, but they're also trying lots of other things in partnership with Google. And I'm really excited. We both know Mike. He's a physician. He's a surgeon, and then he's just a great, really smart, really good guy.
He's a business guy too. Yeah.
He's a great person to lead it. And HCA and Google partnering together is going to bring incredible innovations to market. So it's really good to see.
And we have both talked about generative AI. I have been very bearish about generative AI showing up in the clinical setting, but these names instill confidence for me. HCA, Google Cloud partnering to deliver it in the ED department with Mike at the helm. I think this is a development we really need to watch because this to me feels like either it will have legs and it will work, or it won't for whatever reasons, and
they'll stop it.
Right?
Yeah.
So this will be something to really watch.
Yeah. The reason I'm excited about this is that, as you say, neither of these companies, HCA or Google, are going to do something in a cavalier, half-hearted way.
Nope.
They're really buttoned up and they're really good. And I'm excited to see sort of what comes out of it. And it's nice that we are right here in HCA land.
Yeah, it's fantastic. All right, man. Look, long show, but good one. And as always, thank you, Vic, for pulling it all together.
So next week, you're going to host it without me.
Yes. So next week, I'm going to be in Chicago over the weekend for an Aspen Institute Health Innovators Fellows reunion. It's a mouthful. But on Friday, we're going to be recording a tag-teamed podcast with the folks at Portal Innovations in Chicago. And so we're going to do a live show. It's going to have a panel with some of my fellows from my class, some fellows from other classes, which would be really, really cool. So I'm giving Vic the week off. He has done incredible work for almost 20 episodes pulling together these shows. So I'm giving him the week off. And our next show will be a couple of days late because they're going to do the editing on it. So it'll probably be like Monday instead of Friday, Saturday when we'll get that out.
We'll have some new voices from Aspen Fellows.
Yeah, it'll be great. So look forward to that. And then we'll come back the following week with Vic and I as usual.
Yeah. All right. Happy Labor Day. Go
Happy
kick
Labor
ass.
Day. Thanks, man. Appreciate it.